Sir, with all your permission, I'm starting this session.
Yes, go ahead.
Yeah. Good evening, everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, Professor Dr. Vitul K. Gupta, sir. Sir has done MD in Medicine, FICP, FCSI, FACP, FIACM, Health and Human Rights Activist, Honorary Teaching Faculty, AIMS, Bhatinda, and consultant at Kishori Ram Hospital and Diabetes Care Center, Kishori Ram Road, Basant Bihar, Bhatinda, Punjab. Today, sir is going to discuss on a topic hyperkalemia, updates on outcomes and therapeutic strategies. Let me tell you overview of the topic. Hyperkalemia is a frequent abnormality seen in the patient with chronic kidney disease and is associated with a higher risk of mortality and malignant arrhythmias. Over the past few years, the development of novel potassium blinders has been in a new era of hyperkalemia management, while maintaining a use of beneficial medication such as renin, angiotensin, aldosterone system inhibitors. And to know more about this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Thank you very much. I must compliment and thank IJCP for giving me this platform to discuss rather important topic of hyperkalemia. So topic of today is updates and outcome and therapeutic strategies related to hyperkalemia. Next slide, please. This is my brief introduction. Next. So I start the lecture by paying tributes to my late father, Comrade Vedprakash Gupta, and thanking Professor Dr. Gurpreet Singh Wander, my mentor, my senior, my friend, and Dr. Paramjit Singh Aulak, who gave us direction in clinical medicine. Next. So to introduce the subject, the normal homeostasis of potassium, that is the most abundant cation in the body, is crucial in maintaining health. Balance between intracellular and extracellular potassium is really very important in normal cell membrane electrophysiology in cardiac muscles, skeletal muscles, smooth muscles, and nerve cells. So all the muscles and nerve cells are dependent upon the balance between intracellular and extracellular potassium. Of these, cardiac electrophysiological problems are most dangerous, leading to arrhythmias, conduction abnormalities, and asystole. So out of all the muscles, we all know that cardiac muscle is important. And if there is any problem in cardiac muscle, that will directly lead to mortality and morbidity. Evidence suggests that both high and low potassium levels are associated with higher mortality, depicting a typical U-shaped association. Next. Next. Definition of hyperkalemia. If we consider definition, there is no universally agreed or accepted definition for hyperkalemia. So it may be defined as potassium concentration above the normal limits of normal more than 5.0 millimoles per liter to 5.5 millimoles per liter. Most guidelines classify hyperkalemia by severity. Mild hyperkalemia is graded when the potassium levels are between 5.5 and 5.9 millimoles per liter. Moderate when it is 6.0 to 6.4 millimoles per liter, and severe hyperkalemia is labeled when potassium levels are more than 6.5 millimoles per liter. Although in practice, treatment strategies depend upon the patient's clinical condition and rate of change in serum potassium levels rather than absolute potassium. So we must consider the patient's clinical condition, the rate of change in serum potassium levels, as well as the ECG changes rather than absolute levels of potassium. Next. Outcomes of hyperkalemia, where hyperkalemia is responsible for increased morbidity and mortality in general population, especially in cardiovascular diseases, kidney diseases, and in critically ill patients. So three group of patients are at more risk if there is hyperkalemia. Hyperkalemia, the most common electrolyte abnormalities with unpredictable outcome because of arrhythmias, cardiac arrest, and sudden death can occur at any time and is generally fatal when the potassium levels are more than 10 millimole per liter. Patients with extreme hyperkalemia have been reported to survive depending upon the condition as well as the rate in increase of potassium levels. In indoor patient department, patients with hyperkalemia had significant higher mortality of 18.1% than hypokalemia, that is almost about 5%, or normokalemia, that is about 3.9%. So if we consider the number of patients, more patients had mortality with hyperkalemia as compared to hypokalemia or normokalemia. Next. Evidence showed that prolonged hyperkalemia and AKI are independent predictors of in-hospital mortality. Data suggests higher mortality with potassium levels of more than 4.5 millimoles per liter in acute myocardial infarction and in heart failure. Clinical presentation of hyperkalemia may include progressive weakness resulting in flaccid paralysis and depressed tendon reflexes and paresthesias, because it is affecting the skeletal muscles as well as the nerves. And most importantly, if it is affecting the cardiac muscles, there is more increase in morbidity and mortality. These presentations are benign and ultimately progress to dangerous cardiac rhythm and conduction disturbances because of the effects on cardiac muscles and the conducting system of the heart. Next. Classical ECG changes include peak P waves, prolongation of PR interval, loss of P wave, widening of QRS complexes, bradycardia, and ultimately a sine wave or asystole is there in hyperkalemia. Retrospective data suggests that hyperkalemia with abnormal ECG has a higher mortality rate. Poor correlation with ECG changes and K levels is also shown. So both the things are there. If we have abnormal ECG, it suggests higher mortality rates, but sometimes the ECG changes also do not correlate with the potassium levels. Chronically dialyzed patients may not show any ECG changes despite of being higher potassium levels. Many observational studies have suggested more immediate or early adverse effects of hyperkalemia than long-term effects. Maybe in a chronically ill patients, slow increase in potassium levels, the adaptive mechanisms they set in and they are adapting to ECG changes. So ECG changes may not manifest if we consider absolute higher levels of potassium levels because of very slow increase and adopting the mechanism. Next. A study conducted in hospitalized patients suffering from acute myocardial infarction showed that potassium level of more than 5 millimoles per liter were associated with higher risk of ventricular fibrillation. A large study involving more than 2.5 lakh hospitalized US veterans showed association of potassium levels of more than 5.5 millimoles per liter with significant increased one-day mortality. It also showed substantial increased risk in normal renal functions as compared to severe CKD at comparable levels of hyperkalemia. That is what we have discussed in the previous slide, that severe CKD patients may not have the hyperkalemia related morbidity and mortality as compared to normal renal functions, because we can explain that for less risk in more advanced CKD is unclear, but it may be due to activation of adaptive mechanisms to sustained hyperkalemia in CKD. Next. So if we discuss the evaluation, ECG is the first and most important investigation in patients with hyperkalemia. ECG manifestations provide risk stratification and guided management strategies. So in treatment of hyperkalemia, generally we depend upon the management strategies as manifestations of ECG. So it is very important to note that there is poor correlation between the increased potassium levels and ECG changes because of the adaptive mechanisms. And if the increased levels are achieved by very slow increase, the rate of rise in K levels is more important than absolute potassium levels, because chronic hyperkalemia at higher potassium levels may have relatively normal ECG changes, and as compared to sudden rise of potassium levels, which may manifest with significant ECG changes at lower potassium levels. So it is not the absolute potassium levels which are important, it is the rise in potassium levels which are important, because of adaptive mechanisms when there is slow rise in potassium, and they may reach higher levels as compared to the sudden rise, they have mortality at lower levels. Next. So this is the beautiful cartoon giving us the indication that how ECG changes are there. Increased potassium level gradually causes ECG changes in dose dependent manner, but rate of rise of potassium levels are very important. So that is what I am stressing again and again, that more important is rate of rise of potassium levels rather than the absolute potassium levels. So if potassium levels are between 5.5 to 6.5, we can expect tall peak T waves. Potassium levels of 6.5 to 7.5, we expect loss of P waves. And if the potassium levels are between 7 to 8, there is widening of QRS complex, and potassium levels from 8 to 10, the cardiac arrhythmia, sine waves, and asystole sets in. So if we compare ECG changes between hypokalemia and hyperkalemia, easy to remember, hypokalemia will have the depressed or inversion of T waves, ST depression, and prominent U waves. Whereas in hyperkalemia, as we have discussed, we expect peaked T waves, P wave are flattening, PR interval is prolonged, and there is wide QRS complex. Next. So this is the graphic representation of ECG correlation with the potassium levels. At 5, we have already discussed, we have peaked T waves. At 6, there is loss of P wave. At 7, there is wide QRS complex, and more than that, we expect ventricular fibrillation and sine wave pattern. So we must remember that if there are ECG changes, we need to treat hyperkalemia on emergency basis. Next. So additional investigation should include blood urea nitrogen, serum creatinine, urine analysis, urine potassium and sodium, urine osmolarity, serum calcium levels, complete blood counts. So these are to know the associated comorbid condition and risk stratification. Next. So here the pseudo hyperkalemia needs to be mentioned. The pseudo hyperkalemia is false elevation of potassium levels because of faulty specimen collection, handling, or other causes. It's very common presentation. So differentiation between pseudo and true hyperkalemia is important before initiating aggressive treatment. An important distinction between hyperkalemia and pseudo hyperkalemia is presence or absence of symptoms. So if they are present, we consider it as true hyperkalemia. If absent, we should consider pseudo hyperkalemia. Next. Pseudo hyperkalemia is elevation of potassium levels during collection, storage, and handling of the blood samples. It can result from increased tourniquet tension, increased pressure from patients' fist being clenched, mechanical lysis of hemocytes during pneumatic tube delivery of samples to lab or centrifugal process. Leukocytosis can drastically change the reported potassium levels without recognition. That sample may be hemolyzed since red blood cells may remain intact. Next. So, what are the therapeutic strategies? It suggests that therapeutic strategies for management of hyperkalemia should be guided by cardiac manifestations identified on ECG rather than absolute potassium levels. Hyperkalemia presenting with ECG manifestations should be considered a potential life-threatening requiring urgent intervention. Severe hyperkalemia without ECG changes should also be managed aggressively because of limitations of ECG in predicting the cardiac toxicity. So, whatever the case may be, if there is increased level of potassium, we should treat that. If there is ECG changes, we consider it as potentially dangerous. Even if there are no ECG changes, still we should treat hyperkalemia. Next. Generally, a three-stage approach is being followed to treat hyperkalemia. Immediate control of cardiac adverse effects of hyperkalemia, rapid lowering of potassium levels by redistribution of potassium into cells, because ultimately the extracellular potassium is there and we push the extracellular potassium into cells, that is intracellular potassium, and that is how we decrease the extracellular potassium. And third strategy is removal of potassium from the body. So these are the three strategies considered to treat hyperkalemia. Next. So, under the immediate control of cardiac adverse effects of hyperkalemia, we suggest intravenous calcium protects the heart by stabilizing the cardiac membrane, reversing the depolarization blockade, while other measures are initiated to correct hyperkalemia. So, immediately the recommended dose of 10 ml of 10% calcium gluconate or 3 to 4 ml of calcium chloride is given IV in 2 to 3 minutes with cardiac monitoring. The onset of action is within 1 to 3 minutes and action remains for 30 to 60 minutes. So IV potassium to treat hyperkalemia for adverse effect, cardiac adverse effect, best treatment is IV calcium. Next. If there is no change or reoccurrence observed in ECG, then the dose can be repeated after 30 to 60 minutes. To avoid acute hypercalcemia, 10% of gluconate can be given with 100 ml of 5% dextrose over 20 to 30 minutes. IV calcium should be given carefully if the patient is taking digoxin. So calcium increases the effects of digoxin by pharmacodynamic synergism. So history is very, very important because generally in hyperkalemia, if patient is taking digoxin, we should give IV calcium very carefully. Next. Calcium is traditionally considered contraindicated in hyperkalemic patients with digoxin toxicity for the fear of stone heart syndrome, an irreversible state of global myocardial contraction. This is based on animal evidence and case reports, but more recently, literature found no evidence of increased mortality with calcium administration. In journal, hyperkalemia in settings of digoxin toxicity should be treated primarily with digoxin-specific antibiotic fragments, that is DSFAB, if available. Next. So the second strategy is rapid lowering of potassium levels by redistribution of potassium into cells. IV insulin and inhaled beta agonists help rapid lowering of potassium levels by shifting the potassium into cells. So extracellular potassium is becoming the intracellular potassium. IV insulin, the recommended dose is 10 units of regular insulin IV with 50 ml of 50% dextrose, that is 25 grams glucose in total. The action starts in 10 to 20 minutes, peaks in 30 to 60 minutes, and remains for 4 to 6 hours. In case of hypoglycemia, because once we are giving insulin, patient can go in hypoglycemia, then 10% dextrose is given at the rate of 50 to 70 ml per hour, closely monitoring the plasma glucose. If patient is having hyperglycemia with plasma glucose of more than 200 to 250 milligram per deciliter, 10 units of regular insulin should be given closely monitoring plasma glucose level directly. Next. Inhaled beta agonists, that is albuterol or salbutamol, are useful agents and have addictive effect when used with insulin. Not addictive, additive effect when used with insulin. So if we give both insulin and inhaled beta agonists, both the effects are added and we get better results. These agents should not be used without insulin because 20% of CKD patients are resistant to beta agonists. So if we are giving beta agonist, we must first give insulin and then add beta agonist to the treatment. The recommended dose is 10 to 20 milligram nebulized albuterol in 4 ml of normal saline in 10 minutes. Action starts in 30 minutes and peaks at 90 minutes and remains for 2 to 6 hours. Beta agonist should be used with caution because of risk of hyperglycemia and tachycardia. In routine, the treatment of hyperkalemia, IV bicarbonates have no role except if there is concomitant acidosis. So if there is acidosis, we give IV bicarbonate. Otherwise, we first give IV calcium, then IV insulin for making the extracellular potassium to intracellular potassium and added with inhaled beta agonists. Next. So removal of potassium from body, the strategies are generally done by using sodium potassium exchange resin binders, diuretics, and dialysis. The binders increases the fecal excretion of K with usual doses of 15 to 30 grams every 4 to 6 hours, given in suspension with 33% sorbitol to avoid constipation. Though the binders is commonly used, but currently not favored due to lack of effectiveness and adverse effects, especially bowel necrosis in elderly patients. New potassium binders present several potential opportunities for clinical application and research. Next. Loop or thiazide diuretics enhance potassium excretion and may be useful in non-oliguric, volume repleted, or hypervolemic patients with sufficient renal functions for a diuretic response. So this is real important. If renal function is compromised, then diuretics may not be useful. Hemodialysis is the most effective and reliable measure to reduce potassium levels. Peritoneal dialysis is considered less effective in reducing the potassium levels. Effectiveness of hemodialysis in reducing potassium levels depend upon dialysate, the blood flow rate, the dialysis duration, type and surface area of dialyzer, and plasma to dialysate the K gradient. So it is a specialized job. Whenever the potassium levels are high and we want to go for hemodialysis, these factors should be considered before initiating dialysis. Next. So complications of treatment include hypokalemia, hypocalcemia due to bicarbonate infusion, inability to control hyperkalemia, metabolic alkalosis because of bicarbonate therapy, hypoglycemia because of insulin, and volume depletion because of diuresis. Next. So prognosis is excellent in patients presenting with mild transient hyperkalemia if the cause is effectively diagnosed and promptly treated. Acute or sudden hyperkalemia, severe hyperkalemia presenting with ECG manifestations or cardiac arrhythmias is not treated rapidly and effectively can be fatal in up to 2/3 of the cases. So basically, we need to treat hyperkalemia aggressively to save the patient. Hyperkalemia is an independent risk factor for death in hospitalized patients. Next. So, my dear friends, in conclusion, or take home message is that potassium homeostasis is very important in maintaining normal cell membrane electrophysiology in cardiac muscles, skeletal muscles, smooth muscles, and nerve cells. In absence of universally accepted definition of hyperkalemia, potassium concentration of more than 5.5 millimoles per liter to 5 5 is considered to be high. ECG is most important investigations in risk stratifying hyperkalemia because ECG manifestations provide risk stratification and guided management strategies, but poor correlation between increased K levels and ECG should be kept in mind. Next. So management includes IV calcium, IV insulin, inhaled beta-2 agonists, and if we are using the strategies for removal of potassium from the body, that is sodium potassium exchange resin binders, diuretics, and dialysis. Next. So thank you very much. With this, I invite you all to come for 10th annual conference of Association of Physicians of India, Malwa branch, that is MAPICON 2023, from 21st to 24th September 2023 at Hotel Chapel, Bathinda. For this, we have applied for 16 credit hours from Punjab Medical Council. Thank you very much.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one, sir. I definitely think this session knowledge is going to help all the participants who have joined this session. Sir, we have received some question from the participant end. If you allow, can I take this question with all your permission?
Definitely.
Okay, thank you so much, sir. I can see the first question is, how are ECG findings likely to change as blood potassium level increase in hyperkalemia?
So that I showed the beautiful slide that first change is the peaked T waves, then there is loss of P wave, then there is widening of QRS complex, that is 5 millimole per liter and 6 millimole per liter, 7 millimole per liter will have the widening of the QRS complex, and above that we get arrhythmias in the form of ventricular fibrillation and sine waves. So that is how the level of potassium is correlated to ECG changes, but definitely I have mentioned that it is the rate in increase of potassium levels which matters. If it is slowly increasing, like in CKD, you may not find any ECG changes at higher levels of potassium also. But if there are ECG changes, we need to treat the patient aggressively to save the patient.
Okay, thank you so much, sir, for answering the question, sir. Moving forward, I can see a few more questions are there. I will be taking the second question, sir. The question is, which test should be performed to confirm an incidental lab finding of hyperkalemia?
So hyperkalemia, we should correlate the level of potassium with clinical findings and ECG. We can repeat the test and taking all the precautions which we have discussed in pseudo hyperkalemia, that is the tourniquet tension, and once we shift the blood from taking the vein to the tube, it should be slow, it may not cause hemolysis, so that the potassium levels may not increase, which we call it as pseudo hyperkalemia. So we can repeat the test taking all the precautions and correlate the potassium levels with clinical findings, that is the skeletal muscle findings of weakness, the flaccid paralysis, paresthesias, and ECG changes.
Okay, thank you so much, sir, for answering it, sir. I hope that participant have received his answer, sir. As I can see, sir, there are lots of questions. We are flooded with lots of questions, sir. We will be taking some more questions. And for the session, the third question is, what is the role of signaling molecules in the regulation of sodium and potassium transport?
Which role of which?
The role of signaling molecules in the regulation
Signaling
of
molecule.
sodium and yes, sir.
So it is just an experimental thing. The role of molecules are always there when there is electrolyte imbalance.
Okay, sir. Thank you
Specific
so
role
much,
has
sir.
not been
Yes, sir.
determined as yet in treatment of hyperkalemia.
Okay, sir. I think that the participant have received his answer, sir. We will be taking couple of questions, sir. We have lots of questions, but I can see there is two more important questions. The question is, what is the most common causes for decreased excretion of potassium in hyperkalemia?
What is the most common?
What is the most common causes of decreased exertion of potassium in hyperkalemia?
That is CKD.
Yes, sir. Yes, sir.
Kidney disease is the most common thing, and second is the ACE inhibitors. When we treat the patient with ACE inhibitors, they conserve potassium and potassium levels may increase. So in heart failure, etc., when there is associated renal function impairment, we must watch for potassium levels so that they may not increase and cause danger to the patient.
Okay, thank you so much, sir, for answering all the questions, sir. We will be taking last question for today's session. As I can see, the question is from one of the participant, and he's asking, does the aldosterone deficiency cause hyperkalemia?
Aldosterone deficiency?
Exactly, sir.
So it may not. Basically, aldosterone deficiency is not affecting the potassium levels.
Okay, thank you so much, sir, for answering all the questions, sir. We have lots more questions, but we will be not talking much questions, sir, as you have already clarified all the topic here. Sir, as we don't have the questions, sir, shall we conclude this session with all your
Yes,
permission?
yes.
Okay, thank you so much, sir, for taking out your valuable time once again, and hope to
Thank
see
you.
you again with different topics, sir. Till then, take care of yourself.